information with for the first time. So I'm glad you're here spending an evening with us. For those that don't know me, again, my name is Stephanie Almeida. I'm Executive Director of Smoky Mountain Harm Reduction, as well as Full Circle Recovery Center here in Franklin, Macon County, North Carolina. I like to call it the hills in North Carolina, Appalachian Mountains. Introducing our new logo. I don't know that it's really been public except for Facebook, so you guys are seeing it for the first time. So I'm excited about that. Disclosures, we don't have any financial disclosures. There's no conflicts. We do receive a whole bunch of donations from private donors, from private foundations, North Carolina Department of Health and Human Services, North Carolina Harm Reduction Coalition, and our biggest supporter is Direct Relief. We probably have somewhere around $400,000 in naloxone donations last year through Direct Relief. And we've been able to share those throughout the country since we have a national naloxone shortage right now. So we've been blessed to have a little bit extra and been able to share it with places that have no access. So it's been an interesting year around overdose. Any questions about my disclosures, please let me know. Be glad to let you know we're an open book. Today's training objectives are pretty straightforward. We're going to talk about the opioid syndemic and ways to reduce harm. An opioid syndemic is around HIV, hepatitis C, and overdose, and we're going to learn a little bit more about that. We're going to learn how to prevent, identify, and reverse an opioid overdose using Narcan, intranasal version. I'll talk a little bit about the intramuscular version as well. We're going to learn a little bit more about overamping. It seems like folks just don't know and understand what overamping is. And with so many people using stimulants in our region, it's really important for us to understand, how to identify it and what it looks like. Not so lucky to have a reversal drug for stimulant overdose, overamping, like we do for opioids. So it can be precarious, and knowing when to get help is super important. I'm going to model a lot of language that is destigmatizing. I hope that through some of this conversation, you'll begin to reduce your personal biases relating to people who use drugs and harm reduction. And if anything comes up for you, please put it in the chat and I'll go through it at the end and see if we missed anything. And the last piece is that I really hope folks leave today understanding more about harm reduction, and more importantly, how to make a referral for somebody to a harm reduction program. So not just, hey, we're doing this, but hey, we're doing this and you're using drugs and maybe unsafe, and this is a place to get connected to. So that's what we're working on today. Smoky Mountain Harm Reduction is a 501c3 founded in 2019. Our mission is pretty straightforward: provide substance use prevention, harm reduction, treatment, and recovery support services to people who use drugs and their families. I like to say people who use substances because we're not going to forget tobacco and alcohol, which are the biggest killers in the United States. We tend to not pay attention to them because they're legal, but they are definitely the two most problematic substances relating to death in the United States. Number one and number two sources of preventable death. Our philosophy is to help keep people who use drugs alive and healthy. We come from a peer-led positive change harm reduction model. I'm a person in long-term recovery, and I've also been a person who uses drugs. So we are definitely peer-led, and I love to hear about people's experiences. Coffee's always on. So we're going to start with a very stigmatizing statement. How would most people describe a drug addict? We don't use that language anymore. We don't say drug addict anymore. We try and use language that's person first. A person with a substance use disorder, a person who's having problems relating to his substance use, a person who uses drugs. Person first language is really important because it keeps people's individuality, their autonomy, and their dignity. right? We're all humans. People are more than just their behavior. Using the language clean and dirty. Well, I took a shower this morning. I'm clean, right? And so if I'm clean when I'm not using, I'm dirty when I'm using. And I don't know about you guys, but when I feel dirty, I surely don't feel good about myself. And and so we're directly relating the word dirty to people who use drugs. Oh, his urine's dirty. No, yeah, urine's sterile. Last time I checked, it's sterile, it's clean. And so being careful around our language really can help people be humanized, right? We want to treat each other as humans and as people, and not label people based on how we see them. A lot of people ask me, how did this start? Was it kids using? Was it doctors prescribing? It's a little bit of both. I'm going to watch a quick video about the facts about the opioid epidemic.
The opioid epidemic. It's the deadliest drug crisis in American history, killing about 90 Americans every day, roughly the same number as car crashes. Here are short answers to some key questions about the crisis. What exactly is an opioid? Opioids are a class of drugs that interact with opioid receptors on nerve cells in the body and brain. They regulate pain and affect the brain's reward or pleasure system, which can make people feel high. That makes opioids powerful painkillers, but also extremely addictive. So what is the crisis about? The current crisis started in the 1990s, with the overprescription of opioid painkillers like OxyContin. Over the next decade, a growing number of people became dependent on these drugs. And for many, what started with pills grew into a heroin addiction. Then in 2014, potent synthetic opioids like fentanyl began entering the drug supply in large amounts. Where's the crisis most severe? It's worse in the Midwest, Appalachia, and New England, but it really is a national problem. Synthetic opioids are continuing to enter new markets, especially in the Northeast and South. Why has it gotten so much worse in recent years? Decades of opioid overprescription, an influx of cheap heroin, and the emergence of fentanyl, a synthetic opioid that is 50 times more potent than heroin. Shouldn't we just stop prescribing opioids? Not necessarily. Opioids have improved the quality of life for millions of people, particularly cancer patients and those with acute pain. And suddenly
Oops, sorry. Let me move it.
The opioid epidemic. What
I pressed the
receptors on
chat
nerve
box.
cells in the body and brain? They regulate heroin addiction.
Sorry.
Then in 2014, potent synthetic opioids like fentanyl began entering the drug supply in large amounts. Where's the crisis most severe? It's worse in the Midwest, Appalachia, and New England, but it really is a national problem. Synthetic opioids are continuing to enter new markets, especially in the Northeast and South. Why has it gotten so much worse in recent years? Decades of opioid overprescription, an influx of cheap heroin, and the emergence of fentanyl, a synthetic opioid that is 50 times more potent than heroin. Shouldn't we just stop prescribing opioids? Not necessarily. Opioids have improved the quality of life for millions of people, particularly cancer patients and those with acute pain. And suddenly removing access to opioids from those who are dependent on them to function could easily push people to more dangerous opioids, like heroin or counterfeit pills. So what can be done? There are many variables, but any solution would require controlling the distribution of prescription opioids, expanding access to medication-assisted treatment, and making naloxone and overdose antidote more accessible. In addition, more controversial ideas like drug checking services or supervised injection sites may be necessary to slow the rise in overdose deaths.
So that was in 2017. Many of the things he's talking about have actually happened already. So that's super exciting. So as we look at the opioid epidemic on a national lens, you can see that there are areas that are more affected than others. One of those areas happens to be here in North Carolina. In Western North Carolina specifically, which is the region that I work in. And what we're talking about is a new word. It's called a syndemic. Syndemic is really simply a linked health problem involving two or more afflictions that interact synergistically or at the same time, and it contributes to an excess burden of disease in a population. There was a syndemic years ago. It was called the SAVA syndemic. It was substance abuse, violence, and AIDS. And really, it was happening in areas where folks were living in poverty, really disproportionately afflicted. And so this is what we're looking at now here in North Carolina. Sin means together, and epidemic, we know we had epidemic and pandemic now, right? We know what those are. We've been having this pandemic since before COVID hit, right? This is not a new thing. Yet we're just starting to pay attention to it. And I've been in this field working on this for more than 2 decades. So it's about damn time. This slide's from the state of North Carolina. HIV, STD, hepatitis annual surveillance report in 2017, looking at the syndemic, HIV, hepatitis C, and opioid overdoses. The numbers are pretty scary and have increased dramatically. So we're looking at the opioid overdose deaths. We've got over 3,500 deaths now. So the numbers are just climbing and climbing. And the hepatitis C numbers in 2017, we were just starting to actually count those numbers in North Carolina. So we still are really unsure what the hepatitis C numbers look like, especially since COVID, because nobody's really been testing, right? You can't get to the doctor for anything unless they are ready to give you a COVID test and have you in the hospital, right? No elective surgeries, nothing's happening. Surely people are not getting tested for HIV and hepatitis C. So until we get back to normal, these numbers are going to be dramatically skewed. I think the big issue around Hep C and HIV is the cost of treatment versus the cost of prevention. And so, an average lifetime treatment of somebody living with HIV is about $370,000. And an average lifetime treatment cost for chronic hepatitis C is around $100,000. I don't have $100,000. I'm sure you guys don't have it floating around in a suitcase to give to the hospital. So how do we help our folks that don't have insurance and are living with so many social determinants of health that are just not well? 2015, federal government found an HIV outbreak in Indiana. Once the outbreak was made public, the CDC started to look at the other counties in the United States that may be at risk for an HIV outbreak like this. They used data points such as the number of people who are injecting drugs, the number of, the availability of treatment for like buprenorphine and methadone, the poverty rates. So they used the lens across the whole United States. There's I think there's 3,600 and something counties in the US. Well, 5 of our counties in North Carolina made the top 5% of the nation. Clay County is 63rd out of the entire country at risk of an HIV and hepatitis C outbreak. Clay, Cherokee, and Graham are in my neck of the woods. Burke and Wilkes more towards the west central. This is a big deal. We definitely have a lot of people out here that are living with hepatitis C and that don't have access to care. I don't know if you guys have seen AIDS View. You can go online to aidsview.com or .org, whichever it is. And this particular map is the number of people living with HIV in 2018. What do you guys notice about this map? Can somebody tell me what's blaring them? What do you see? Just take yourself off mute. What do you notice?
Well, it's not in the heartland or in the heartland.
Yeah, not too much happening in the middle of the country. Most of the cases of HIV happen to be in the South, in the Northeast, and in the West. disproportionate numbers are further south. I believe, if I remember the number correctly, we have like 49% of the population of the United States and 53% of the new HIV cases, if those numbers are right. So it's really disproportionate. Yeah, we're in trouble. This is North Carolina. I hear from people all the time, oh, there's no HIV in the West. We don't really have that problem out here. Yeah, this is my county here in Macon. Macon, Jackson, Haywood, Buncombe, right? We definitely have folks living with HIV in the West. And so when we're talking to people about prevention, we need to be talking about HIV and hepatitis C. These are newly diagnosed HIV cases in 2016 by county in North Carolina. You can see that most of the new cases are in the east and in the central part of the state. I don't want to talk too much about this, but I want you guys to be aware that there's been some changes in the way that we talk about people living with HIV. Here on the screen, you have a family, a mom and a dad. Dad's not living with HIV. Mom is living with HIV, and both of their children are not living with HIV. The reason that's possible is because U equals U. Undetectable is untransmittable. Because the CDC has advised us that people living with HIV cannot transmit HIV sexually if they have been in care for 6 months, taken their medication as prescribed, and their viral load is less than 200, they can't give you what they don't have. And so 2018, the state of North Carolina changed their HIV control measures. People living with HIV that are virally suppressed, they met the criteria I just shared, do not have to tell their sexual partners that they're living with HIV. They also don't have to use a condom during sex anymore. If their partner is using PrEP, which is pre-exposure prophylactic, that's something a person takes to prevent the transmission of HIV, they don't have to use a condom during sex either. If both partners are living with HIV, they don't have to use a condom. And now there's been 2 big changes that were super exciting to me. I could have almost done a cartwheel. I was so excited. But people living with HIV can now donate their organs to other individuals living with HIV. Before they would just, burn their organs or throw them away. Now people who are living with HIV have basically their own transplant list. And then the last one is people who are living with HIV can now have their eggs or sperm harvested for fertility. Before, if you were living with HIV, the doctors would not help you have a child. You'd have to go to Mexico or Canada or another place that would assist you with that. On to hepatitis C, we are really looking at 2 epidemics. The first one is the historic epidemic, where we had folks that were chronically living with hepatitis C virus. We typically looked at baby boomers. Those are people born between 1945 and 1965. And we had about 150,000 people living in North Carolina with chronic hepatitis C, but most of them were unaware of their status. And so you start to see the ads on TV for Harvoni and other medications. Baby boomers are now getting tested. And now we have this new emerging epidemic where we have folks that have acute hepatitis C. An acute hepatitis C case is somebody who's newly infected, maybe less than 6 months ago. And so acute hepatitis C cases we're starting to see. The numbers are increasing rapidly. What we're seeing is younger folks that are in more rural areas, definitely poorer communities. And many of these emerging hepatitis C cases are associated with intravenous drug use. So we're moving gears from baby boomers and folks that were on this hepatitis C who's at risk list to everybody. Everybody's at risk of hepatitis C. We all need to be tested at least once. And then if we have risky behaviors, you want to get tested more often. Everybody needs to have a hepatitis C test at least once in their life. Moving on to hepatitis B. So hepatitis B is not curable. For many cases, it can be treated, but not cured. And for many cases, they'll become chronic cases of hepatitis B. As you can see, there are a lot of people that have contracted hepatitis B. There is a vaccine to prevent hepatitis A and B. You can get it at the health department or your primary care physician or a federally qualified health center. If you don't have insurance, it's definitely available. But if you haven't had the vaccine, you really should get it because, as you can see, the numbers are climbing. Hepatitis C rates, look at Western North Carolina here. Our numbers are through the roof. You can see all of this. So we've got to do some things a little bit differently if we're going to prevent the spread of Hep C. Number of cases. So between 2007 and 26 years, in 10 years, we had a 900% increase in acute Hep C cases. These are the cases that are less than 6 months old, newer cases versus chronic people who don't know when they got it and may have had it for decades. Any questions before we move on to opiates? Any questions about HIV or hepatitis C? Are there any in the screen, the chat screen?
I've got a question.
Yeah.
So looking at the map that showed the cases in the western part of the state being more prominent there, how much of that do you think is just more access for screening and just having that available data?
That's a great question, right? And so we weren't testing before. There was no testing happening outside of Asheville in the western part of the state before 2016. I'm the one that expanded the testing out here. Nobody was testing. So who knows, right? Of course, when we start to test, we're going to start to see numbers. But we're seeing numbers across the state that are increasing. It isn't just because we're testing. Now we're testing more often and more universally. And so I think we're going to start finding more and more viruses. The good news is that there's treatment available for hepatitis C and we can cure it. Medications run about $30,000 for an 8 to 12 week regimen of meds. And typically if they comply with the financial requirements, we can typically get people cured for free. So no reason not to get tested. Any other questions? All right. So common opiates. So opiates, there's so many different kinds, but I think these are most common: heroin, morphine, Tylenol 3, OxyContin, oxycodone, roxicodone. We have the kids out here, they're using Roxys. So yeah, the list goes on and on and on. Opiates and opioids. Opiates are synthetic, opioids are naturally occurring, right? So we've got a whole list of meds and street drugs that fall under opiates. I wanted to start off with some overdose numbers. This is a NIH slide, but it only goes up to 2014. We're going to look at some more up-to-date numbers, but you can see it's just been steadily climbing, sadly. Same thing from heroin. Look at the massive jump from 2000 pretty steadily for a decade up until 8,000. So, and now we're over 100,000 deaths last year from opioid overdoses. This is the number from the state. From 99 to 16, we've lost more than 12,000 people in the state of North Carolina. I would love to see this slide updated. I'm interested in seeing what it is now, but I bet it's, I don't know, probably 25,000, I would say. I mean, we're at 3,500 people last year alone. Here's an up-to-date slide from December 2021 from the medical examiner's office. These are suspected overdose deaths. What's important for this slide is the box on the top left, 366 suspected overdose deaths. compared to 288 in North Carolina the year before. So we've got an almost 100% increase in the number of deaths in 1 year. That's a dramatic increase. You can see the percentages down here. Let me move my mouse over here. So in 2019, it was up 5%. 2020, the number went up 17%. We've got a 26% increase for 2021. And look at it, it's at 3,900 people. This slide is for emergency department visits. I showed this slide because the numbers were pretty surprising. For September, this is. By the time it got to December, this number was dramatically different. And I think it had to do a lot with the COVID numbers. I couldn't get the December slide to load. I apologize. Bex, if you want, I can send you those and you can send them out to them. I've got a PDF showing both numbers for December. These are EMS overdose encounters. So somebody calls 911. I've got a person not breathing, not responding here at 3261 Georgia Road. Can you come help me? And so in September of 2020, we had 1,238 calls for help compared to 629 in 2021. So half of the people did not call for help here because we just saw the overdose numbers are increasing, not decreasing. Scary stuff. I thought this was interesting too, where the EMS calls are going. Private residences, 58%, which shows that it's super important for people who use drugs to have support from the people that they live with around reversing an overdose. Every house should have Narcan in it. Some sort of service area, transportation facility, maybe bus station or something, 12%. Outside roadway recreational area, 13.8%. Commercial public building, 6. Businesses should be having naloxone in there. Also, you have an AED machine. Why wouldn't you have a Narcan kit on the wall? Hospitals, schools, and interesting, no EMS calls to prison for overdoses. You want to speculate what happens there. This is a pretty common slide. It shows you the difference in lethality between heroin, fentanyl, and carfentanil. That's how much of the substance would be needed to kill a human like me who's opiate naive. I don't use opiates unless my leg is hanging off. But you can see the volume distance between the heroin bottle on the left and the fentanyl bottle in the middle. You can see why the cartel is not shipping heroin at that volume versus fentanyl at that much smaller volume, right? It just makes business sense. And carfentanil, well, you're talking 1 grain of salt will kill a human. Carfentanil is an animal tranquilizer for big animals like elephants and such. And we have had 1 carfentanil related overdose death on the reservation. I don't know much information about it, but it was confirmed that there was carfentanil present. Fentanyl, here you go. People say, how do you know it's in the drug supply? Well, we tested. So 100% of the test strips in Raleigh, they tested 18 of them, 100% were positive. 136 in Wilmington, 97 were positive for fentanyl. Steady Collective in Asheville, 92%, 85 numbers were tested. 224 in Durham, 74% were positive for fentanyl. So we know that there's fentanyl in the drug supply. We don't have the money for a $1 test kit to give to everybody, unfortunately. So from the prevention side, I tell the people that come to get services from us that they should assume that there's fentanyl present, even if they're using methamphetamine. They should assume that there's fentanyl in everything. All right, shifting gears for a little bit with psychostimulants, and we'll go back to opioids. So what are psychostimulants? So prescription medications like Adderall, MDMA, methamphetamine, and other amphetamine-like stimulants, cocaine, synthetic cathinones, and synthetic cannabinoids, right? Bath salts, good stuff. We don't talk about psychostimulants so often, but we really need to. What does somebody look like that's having a stimulant overdose or an overamping. This slide's pretty cool. I borrowed it from, let's see, this came from International Overdose Awareness Day. And, somebody who's describing that they're having chest pain, not just a pounding heart, right? Their heart's pounding, it's beating fast, but they're having chest pain. You can see that they're sweating or they're really dry, right? Their skin can be beet red and dry as their body temperature rises. Their breathing is rapid, right? So they look like they're hyperventilating, and they may be describing that they're cold or having the chills. Typically, there's disorientation, irritability, anxiousness, and you could see even psychotic behavior. People get really scared when they think they're about to die. So how do we deal with this? So I've got some slides from the Grand Rapids Red Project. This is the best that I've seen anywhere. So thank you to the Grand Rapids Red Project for making this public for access. You can go on their Facebook page and download this. So what is overamping? Happens when the effects of the stimulant becomes overwhelming. We become distressed. It can become dangerous and for sure harmful. Using the word overamping separates it from overdose because it's really different in how they happen, how it appears, and what we do with it. So overdose for opioids and overamping for stimulants. We just spoke a little bit about what some of the stimulants are, but everybody knows what cocaine is, MDMA, ecstasy, and Molly. And then prescription stimulants are used to treat ADD or ADHD. So they're very common, especially the prescription stimulants. And so we really need to be talking about it more. People ask me all the time, what causes it? Well, they take more than they usually do. They could be tired. Maybe they haven't been sleeping for several days at a time. They've been awake. Maybe they've been using multiple days in a row without sleeping at all. Also, the way you use the substance, whether you're smoking it, injecting it, eating it, snorting it, or booty bumping, right? Each substance, each way you use it is different, and the body uses the substance different. And also your physical health, like if you're living with hepatitis C or HIV, or maybe you have COVID, right? You've got COVID and you're sick, and you're just not handling the substance like you would normally, or you normally can. So we talked a little bit about the symptoms on the previous slide, but this also talks about restlessness, hypervigilance, right? You see people looking out the blind all the time, or having this hallucination or delusion, extreme paranoia, extreme agitation, and definitely can be aggressive. Folks are not in their right frame of mind. You may see them have nausea or even vomiting, falling asleep and passing out, which seems abnormal for somebody who's using a stimulant, right? They're still breathing, but they're out like a light. Having chest pain or tightening in the chest, high temperature, the body can't regulate the temperature because of the stimulant, and maybe they're sweating profusely, or they're really dry. A fast heart rate, racing pulse, tachycardia. Irregular breathing, shortness of breath, either one. Any change in breathing is a problem. You may see them have a convulsion or even a stroke. Limb that's a limb jerking, or maybe just completely rigid. Feeling paralyzed while awake, right? Being catatonic. Severe headache. Hypertension, which is high blood pressure. Their heart is pounding as fast as it can go out of their chest, and the blood pressure is sky high. You may see them teeth grinding, holding their jaw tight, holding it. And then, of course, insomnia, decreased need for sleep, which is normal for that substance. And then tremors, right? Could have a seizure, tremors, convulsions, whatever that might look like. So this is what we're talking about with overamping. How do you know it's an emergency? versus he's going to be okay. So when a person starts to experience confusion, restlessness, hypervigilance, right? This is more than just a little bit of paranoia. This is serious stuff. Very intense panic, right? They cannot calm them down. Hallucinations, delusions could be visual hallucinations. They could see somebody that's not there. They could hear somebody speaking that's not there. They could feel something on their skin, tactile, all the above. And then, of course, that increased aggressiveness. When we call for a medical emergency, super important is any increased heart pain, right? Crushing feeling in the chest, worse pain when they move their body, the sweating is getting worse. Anytime you have a seizure with somebody, they need medical care. Overheating, a body temperature over 104 degrees. Definitely a stroke, right? So ask them to smile. If their smile is off on either side, any facial droop, inability to speak, yeah, all of that. And then loss of contact with reality, psychosis. And, it doesn't happen in a lot of cases. It's rare for somebody to completely disconnect like that, but it can happen. Call for help. How do we prevent folks from overamping? So if somebody is using stimulants and they're telling you that they're starting to experience some of these overamping symptoms, number one thing that I want to do is I want them to be comfortable. So if they have a button on their pants, they can open their belt, open their pants. They can open around the neck if they've got a button-up shirt, even take the shirt off so they don't feel any pressure there. Put a cold cloth around the back of their neck or on their forehead. But it's really important that people who use drugs have regular visits with their doctor. So and having that visit with the doctor to be able to talk to them openly and honestly about their substance use so that they can learn how to take care of themselves despite using substances, right? Got to find a doctor that you can trust. Some of them are really understanding, and their job is to do no harm. So if you find a doc that isn't understanding, then go find another one. Come see us and we'll find you a doc that you can work with. Getting regular blood pressure and cholesterol and circulation checked, really important. Blood pressure increases is part of the overamping, and if you have high blood pressure, it's not going to take a lot for you to trigger a problem. So making sure that your heart is healthy and that you're checking your blood pressure and your cholesterol and circulation is super important, being healthy there. And then normal basic care, making sure you're eating, sleeping, drinking fluids, especially if you're up for several days in a row. Dehydration is a big problem. So these are just some recommendations that can prevent overamping and help someone who's using stimulants be as healthy as they can. Any question about overamping or stimulants? It's new for most of us. All right. So we've been talking about harm reduction, ways to reduce harm. What is it? For me, it's any positive change. People ask me all the time, oh, you just can't fix people. Well, that's not my job. I can barely fix myself, right? And so harm reduction refers to the way we work with folks, where we're removing those harmful consequences associated with their high-risk behaviors, right? We're not here to save people. We surely can't rescue people. And we always say we walk beside them, right? Nothing about us without us. Meet them where they're at. But what does that really mean? When we're talking about people who use drugs, what does it mean to meet them where they're at? So harm reduction is a way to help people change their substance use without demanding immediate and lifelong abstinence. It is not my job to tell you what to do with your substance use. It uses many creative strategies to keep people alive and safe while they figure out how to develop healthier relationships with drugs. For some people, that means abstinence, and for others, that means moderate or safer use. And this is from Over the Influence. I couldn't have said it any better. Can't demand you to do anything. I can't even demand my kids to do anything, let alone somebody else, right? So how do we work with people in a way that they see themselves worth taking care of? Right. This is a video. I don't know, might cry. This is Dan Big from Chicago Recovery Alliance. Let's hear from him and then I'll tell you about it. This is a SAMHSA video.
Well, for the past 27 years, we have operated what we call harm reduction outreach, and that is our philosophy is simply to assist any positive change as a person defines it for him or herself. So instead of having chaotic, out of control addiction on the one hand and abstinence on the other, and saying these are the only two choices, we've said there's a huge productive middle ground, any positive change and any improvement. So we try to operationalize any positive change. You would define it for yourself, I would define it for myself, and then we as an organization would provide the most cost-effective and scientifically proven means to accomplish those things. But the choice is yours, both to what and intensity. So for almost 40 years, I've been an addictions counselor, and the focus has been on struggling between those two poles, chaotic, out-of-control addiction and abstinence. And the idea was to migrate people who are chaotic and out of control in their drug use to people who are abstinent. That is the traditional model of addiction treatment. Unfortunately, it's inconsistent with human behavior, human condition, and there's a huge fertile field between the two that would be called improvements. In other words, using in a way that does, separating drinking and driving, for example, hugely successful public health intervention. It's not that we stopped drinking, it's not that we stopped driving, it's that we began to develop mechanisms for separating the two. You see them most on New Year's, things like this where, where there's a designated driver, or cabs or CTA, or the trains are offering free rides and so forth. We realize there's a danger to that, and so we separate the two. It's not that we're prohibiting one or the other. We could, but we don't, because we know it wouldn't work. And that's basically all harm reduction says, is public health is the most important thing. The health of your children, the health of my children, the health of the community, that has to be first. We have to put in the background moralism, condemnation, one's perception of how one should be. And so what we're talking about for the first time is affirming and even rejoicing in improvement, not perfection, improvement. And humans are really good at improvement. We are not so good at perfection.
So Dan Big was the founder of our nation's overdose prevention naloxone distribution. Because of him, we have naloxone in North Carolina. Dan died a couple of years ago of an opioid overdose. Despite knowing what to do, how to keep himself safe, it still happens that we lose folks. And I think especially with people that are in professional positions like us that hold credentials, there's no room for us to be able to talk about our substance use in a way that helps us stay safe. And so I just always like to mention Dan Big. You might see me post Big Love, BIGG. He's just an amazing human, and he's missed so much. He had guts the size of Kansas. to go against the government and law enforcement to distribute naloxone across the country. So just an amazing guy. I hope that helps you understand a little bit about what we're talking about with any positive change, right? So I'm 5'4" and I'm 240 pounds. I'm morbidly obese. The doctor says my fat is killing me. And so I'm on a diet to lose weight. I want to lose 100 pounds. I'd like to be 140. All of this weight is trauma weight from working with people who use drugs. I've gained so much weight in my 20 years of doing this work. And so let's say the doctor says to me, gee, Stephanie, you got to lose 100 pounds, but you can't stand on the scale until you think you've lost 100 pounds. That's perfection. I stand on the scale once a week. I notice my weight is dropping. It motivates me and makes a commitment to my desire to continue to try and lose weight. If I only looked at the perfection of 100 pounds on the scale, I would never be able to continue with my healthy eating, right? It's that weekly check-in that shows me that what I'm doing is making change, and that positive change happens incrementally and not just, hey, you lost 100 pounds, you look great, right? So that's what we're talking about with substances as well. All right. So what's an opioid overdose? Opioid overdoses happen when the brain gets too much of a substance, and it tells the brain to slow down respirations until they stop. It's more than just uses directed with prescriptions too. A lot of people say, oh, drugs are safe. You get it at the pharmacy, right? You can take 2 of those, you'll be okay. Well, the reality is that the most common risks for opioid overdose happens in a dose and change in purity. So maybe the person you were buying for got arrested. Maybe the person has addiction history and just came out of detox. They've been in detox 5 to 7 days. Well, their tolerance has dropped dramatically and could cause them to have an overdose on the same amount of substances that they were using before they went in just 1 week ago. Most commonly, we see with overdoses that there is polypharmacy or polysubstance use. So mixing alcohol with opiates, stimulants with opiates, cannabis with alcohol, with opiates, whatever it looks like. And so that mixing of the substances, sometimes 1 and 1 makes 2, sometimes 1 and 1 makes 5. Sometimes 1 and 1 makes -5, especially when we're talking about things like naloxone. Adverse reactions with substances can occur with comorbidities when people are living with something else, such as, I don't know, COVID. Co-pharmacy, so they're taking more than 1 substance. One's prescribed, maybe a sedative from the doctor with a benzo, maybe a Xanax, Klonopin, Valium, whatever it looks like. Genetic susceptibility, right? We know family history plays a part in people's tolerance levels. They're born with an initial tolerance set by heredity. We also know that there's a 4 times higher risk of somebody having an alcohol use disorder, a substance use disorder. If they have a family history, they're 4 times more likely to have a problem themselves. User error. Oh, did I take that pain pill? I don't know. My hip still hurts. Let me take it. I must have forgotten it. Period of abstinence we described. Could be a jail. Maybe somebody has a probation violation and they got to do a weekend dip, right? They go in Friday, they come out Monday. Their tolerance is already lowered enough to have a problem. Switching opiates. Well, I used to buy these Roxys from Mary, and Mary's in jail. So Fred only has oxycodone. So I'm switching substances. And of course, family members could help themselves to medication you have at the house. But these risks need to be shared with folks so that they understand some of them. So very higher overdosing. What's the difference? It's really simple. If somebody's overdosing, they will not respond to you. They won't answer you. If you cause them pain, they will not respond. So a person who's really high, you may notice that the pupils are constricted if it's opiates. Pinpoint pupils mean opiates on board. And if they're contracted, they look like saucers, maybe most of the eye is black, that's usually withdrawal with opiates. With stimulants, it's the opposite. So withdrawal from stimulants, you'd have a pinpoint pupil, and opiate and stimulants on board would be the opposite with the big pupil, big black pupil. If you lift their arm, the arm probably looks droopy and not any control with it. They could look like they're knotted out, like they're passed out. They could be scratching, relating to opiate use, often makes people's skin itchy. Their speech could be slurred, but even though they look like they're out of it, they will respond to outside stimulus, like a light shake or a loud noise or a friend calling their name, right? If they respond, they do not need Narcan. So we're not just using Narcan to get somebody from being high, right? It's a medication that's used to reverse an overdose. If they respond, they're not overdosing. Now, they may be in the process of overdosing and you want to stay with them, but you don't necessarily have to administer naloxone or Narcan unless they're not responsive. If you think that they're really high, don't leave them alone. If they're conscious, get them up, walk them around, monitor the breathing, make sure they're okay. And quick video about what nasal Narcan administration looks like. So this is how it comes. Let me show you what this looks like. So we have this little Narcan nasal. Whoop. There we go. And it's really simple to open. It's just got this piece of aluminum foil on the back. So you pull it apart. Sorry, it's a little blurry. I'll put it in the middle better, right? You've got that piece of paper right there. Those are the directions. So in every Narcan foil pack, and there's 2 in a box, you have directions that are in there. When you take it out of the foil, it's ready to go. Doesn't have any cover on it. It's really simple. It's only maybe 3 inches. Be really careful when you handle this unit. You do not want to press on the plunger in any way. As soon as you touch that plunger, it's going to start to spray out the top. And let me show you how little medication is in here. If I can get this one. And there it goes. Sorry. A tiny glass tube. So can you see how little that is? What's it? Maybe about 1.5 inches. And half of it has a rubber stopper in it. So only half of this little vial is medication. So don't spray the middle because you won't have any medication left. So we hold it on the outside edges, which is different from what they're going to tell you during this video, right? They're telling you be ready to use it, and I'm showing you a different way to hold it on the outside until you have it ready. So we'll talk about it again after this video. Really simple.
If you know someone who takes prescription opioids like Percocet or Oxycontin, or illegal opioids like heroin, then you should know about the risk of an accidental, life-threatening opioid overdose. In fact, over 56% of overdoses happen in private homes beyond the immediate reach of doctors and nurses. There's a way for you to help someone who is experiencing an opioid overdose, even if you don't have specialized medical training. In this video are instructions for use, as well as the uses and safety information you should know for using Narcan. But first, it's important to be able to recognize the signs of an overdose. Signs of an opioid overdose include not waking up or responding to your voice or touch, breathing that is very slow, irregular, or has even stopped. The dark center part of the eyes becomes very small, sometimes called pinpoint pupils. Fingernails and lips turn blue or purple, a slow heartbeat, weak pulse, or low blood pressure. If someone has these signs, here's how you can help. Narcan nasal spray is a medicine that reverses the effects of an opioid overdose. Narcan nasal spray is not a substitute for emergency medical care. Repeated doses may be necessary. As with any drug, you need to be aware of important safety information about its use. Please pay particular attention to the indications and important safety information at the end of this video. Also, please see the accompanying full prescribing information in the use of this product. Narcan nasal spray was designed for use wherever an emergency opioid overdose happens. Because it doesn't require specialized medical training, it can be given to someone by following these instructions. First, lay the person on their back. Then, remove the device from the box and peel back the package. Hold the device with your thumb on the bottom of the plunger and 2 fingers on either side of the nozzle. Tilt the person's head back and provide support under their neck with your hand. Place and hold the tip of the nozzle in one nostril until your fingers touch the bottom of their nose. Press the plunger firmly to give the dose into the person's nose. After giving the dose, remove the device from the person's nostril and move them on their side, positioning their hands under their head. Call 911 and get emergency medical help right away after giving the first dose of Narcan nasal spray, even if the person wakes up. Narcan is not a substitute for emergency medical care. Keep the person under observation. If the person doesn't respond by waking up to voice or touch or breathing normally after 2 to 3 minutes, administer the second dose provided in the box in the alternate nostril. If they respond and the signs of an opioid emergency have returned after Narcan nasal spray is given, then give another dose in the alternate nostril using a new device and watch them closely until emergency help is received. Additional doses may be given every 2 to 3 minutes until they respond or emergency medical help is received. After using Narcan nasal spray, put the device in its box and then dispose in a place safe from children. Narcan nasal spray delivers a consistent, concentrated 4 mg dose of naloxone that can reverse the effects of a life-threatening opioid overdose in minutes. Visit Narcan.com to learn more. There's a way for you to help someone who is experiencing an opioid overdose, even if you don't have specialized medical training. Indications and important safety information. What is Narcan nasal spray? Narcan nasal spray is a prescription medicine used for the treatment of an opioid emergency, such as an overdose or a possible opioid overdose with signs of breathing problems and severe sleepiness or not being able to respond. Narcan nasal spray is to be given right away and does not take the place of emergency medical care. Get emergency medical help right away after giving the first dose of Narcan nasal spray, even if the person wakes up. Narcan nasal spray is safe and effective in children for known or suspected opioid overdose. What is the most important information I should know about Narcan nasal spray? Narcan nasal spray is used to temporarily reverse the effects of opioid medicines. The medicine in Narcan nasal spray has no effect in people who are not taking opioid medicines. Always carry Narcan nasal spray with you in case of an opioid emergency. Use Narcan nasal spray right away if you or your caregiver think signs or symptoms of an opioid emergency are present, even if you are not sure, because an opioid emergency can cause severe injury or death. Signs and symptoms of an opioid emergency may include unusual sleepiness and you are not able to awaken the person with a loud voice or by rubbing firmly on the middle of their chest, breathing problems including slow or shallow breathing and someone difficult to awaken or who looks like they are not breathing. The black circle in the center of the colored part of the eye is very small, sometimes called pinpoint pupils, and someone difficult to awaken. Family members, caregivers, or other people who may have to use Narcan nasal spray in an opioid emergency should know where Narcan nasal spray is stored and how to give Narcan nasal spray before an opioid emergency happens. Get emergency medical help right away after giving the first dose of Narcan nasal spray. Rescue breathing, or CPR, may be given while waiting for emergency medical help. The signs and symptoms of an opioid emergency can return after Narcan nasal spray is given. If this happens, give another dose after 2 to 3 minutes using a new Narcan nasal spray and watch the person until emergency help is received. Who should not use Narcan nasal spray? Do not use Narcan nasal spray if you are allergic to naloxone hydrochloride or any of the ingredients in Narcan nasal spray. What should I tell my healthcare provider before using Narcan nasal spray? Before using Narcan nasal spray, tell your healthcare provider about all of your medical conditions, including if you have heart problems, are pregnant or plan to become pregnant. Use of Narcan nasal spray may cause withdrawal symptoms in your unborn baby. Your unborn baby should be examined by a healthcare provider right away after you use Narcan nasal spray. Are breastfeeding or plan to breastfeed. It is not known if Narcan nasal spray passes into your breast milk. Tell your healthcare provider about the medicines you take, including prescription and over-the-counter medicines, vitamins, and herbal supplements. What are the possible side effects of Narcan nasal spray? Narcan nasal spray may cause serious side effects, including sudden opioid withdrawal symptoms. In someone who has been using opioids regularly, opioid withdrawal symptoms can happen suddenly after receiving Narcan nasal spray and may include body aches, diarrhea, increased heart rate, fever, runny nose, sneezing, goosebumps, sweating, nausea or vomiting, nervousness, restlessness or irritability, shivering or trembling, stomach cramping, weakness, increased blood pressure. In infants under 4 weeks old who have been receiving opioids regularly, sudden opioid withdrawal may be life-threatening if not treated the right way. Signs and symptoms include seizures, crying more than usual, and increased reflexes. These are not all of the possible side effects of Narcan nasal spray. Call your doctor for medical advice about side effects. The risk information provided here is not comprehensive. To learn more, talk about Narcan nasal spray with your healthcare provider or pharmacist. The FDA-approved product labeling can be found at www.narcan.com/pdf/narcan-prescribing-information.pdf or 1-844-4NARCAN. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088. Please see full prescribing information, including the patient information for Narcan nasal spray.
All right, so now that we had the Adapt Pharma full information from this, using this is really simple. You open it, it's ready to go. You put it in the nose and you spray it. It can't get any simpler than that. It's child's play. A child can do this, right? And so teaching people how to reverse an overdose is more about identifying that there's a need, right? Person's not breathing. Let me move into the next slide. The person's not breathing. They're not responding, whatever it looks like. Let me go back. So naloxone, this intramuscular version of Narcan, has been around since 1961. I'm 52. That's before I was born, right? This is an old, trustworthy medication. The beauty of this medication is that it has a higher affinity for the opioid receptor. So affinity, you can think of it as like a magnet. Now you have magnets on your refrigerator and you close the door and all the magnets fall off, right? The kids' magnets. I don't know why I bought those stupid things. They never stay in the fridge. They don't have any affinity for the metal on the fridge. And then you have a magnet that can pick up a car and move it across to the squishing machine, right? Picks the whole thing up and carries it all the way across. And so that's what we're talking about with affinity with naloxone. It has a super high magnetism. It goes right to the opioid receptor and it displaces the opiates such as heroin or prescription pills from the receptor. If you can think of it as like a condom on the receptor so that nothing can get in, right? It's protecting it. The effects of the naloxone last for anywhere from 30 to 90 minutes. The more you give them, the more naloxone you give them, the higher the symptoms, the worsening of the symptoms of withdrawal. The whole purpose of this medication is to cause precipitated withdrawal. That withdrawal helps them breathe again, right? We want them to breathe. Maybe they're breathing every 3 breaths every minute because they're slowly dying from this opiate that they've taken. So this medication takes the opiate off the receptor and then the brain breathes again. It's really an amazing substance. So this is the intramuscular version you see in the picture on the right. It has an orange cap on the top and that cap simply pops off and then you load up the syringe. I'll show you how to do it in just a minute. The safety profile, this medication is very safe despite what you just heard on the video. There are some cases where it can be extremely dangerous for withdrawal to happen. Pregnant women, mama goes into withdrawal, baby goes into withdrawal. Mama could have a miscarriage from being in withdrawal. If you give this medication to mama and she goes into withdrawal, she could miscarry the child for sure. Allergy is the only known contraindication. And we just heard that any babies that are less than 4 weeks old, if they're on a medication for neonatal abstinence syndrome, which is a baby born in withdrawal, that it could cause severe issues and possibly death if you were to give them naloxone during that early time. When we give naloxone in the lay community, we give a very mild dose. This intramuscular is at 0.4 milligrams. The intranasal is at 4 milligrams. Narcan nasal spray, they just made an 8 milligram dose, so double the milligrams. There's a lot of discussion across the nation of whether or not this is going to put people into a more precipitated withdrawal, unnecessarily cause them discomfort. Sometimes it's needed, but most often than not, the dose is appropriate for what we're giving already. Yeah, good stuff. If somebody walked up to a person laying on the sidewalk and they were non-responsive and called 911, Narcan or naloxone is part of the coma cocktail that EMS responds with to every patient. It's that safe. So this person has never even spoken to EMS and they're administering a medication to them just in case it is an overdose. And so it's pretty safe. There are some laws in North Carolina that help us distribute medication like this, that help us administer medication like this. I don't have MD initials after my name. I'm not a PA. I'm not a nurse practitioner. I'm not a pharmacist. We needed to pass laws in order for us to be able to distribute naloxone and administer naloxone safely. And so the North Carolina Naloxone Access Law was enacted years ago, I want to say 2014. And it protects people who give naloxone to someone who's having an overdose. So I open the door in McDonald's bathroom, there's a lady laying on the floor. I try to get her to respond. She doesn't answer. I give her naloxone, but she dies. You know, I'm not going to be in any trouble for giving this person the medication, even though there was a death. So we're doing the best we can to use reasonable care, and we're protected 100% by the law for a lawsuit for neglect. Under the Good Samaritan law, now the Good Samaritan law is a little bit more complicated. And so if you're a person who's using drugs, or you're at a place where people are using drugs, and you call for help, you call for medical assistance for somebody who seems to be experiencing a drug-related overdose, if you call 911, and you're the first person to call, you give your name to the 911 system. Hi, 911, this is Stephanie Almeida. I'm at 3261 Georgia Road in Franklin, and there's a person not breathing and not responding in my lobby, and I need help. That's all I'm going to say. Notice I didn't say anything about drugs. The person is not responding and not breathing. I'm just giving the facts. That gives you a priority call over the other EMS calls, and they're going to send help right away. That's what you want, right? Now, if law enforcement was at your location executing a search warrant or probation visit or something along that line, and they found an overdose, you would not be covered under this law. Also, any evidence for prosecution of a drug-related offense that was obtained by law enforcement because you sought medical assistance, they cannot prosecute for that up to a certain amount. I believe it's about a gram, and methamphetamine is not included. I should make a slide with the limits on there. Let me make a note. Sorry. All right. And then there's also Safe Call campaign, because the Good Samaritan law doesn't only cover illegal drugs, it also covers alcohol. And so if you've got some kids that are at a party and somebody has had too much to drink, they can definitely call for help, and the person calling and the person who has the overdose cannot be charged. They can be arrested, but they can't be charged. So this is under the Good Samaritan law, and these can be found on the state website for North Carolina under morepowerfulnc.org. That is the North Carolina opioid overdose website, well, opioid website. And so you can get lots of information there about resources. Back to naloxone nasal, right? Easy, easy peasy. The barrier is the cost. So 2 doses of this medication, if I was to walk into a pharmacy, would be $175 for 2 doses. My cost as a community-based organization is $75 for 2 doses. We can't afford this, not at the volume of naloxone that we distribute. So we're blessed. The state just sent us 100 kits. It won't last long, but at least, you know, we've got a few. We went over the directions, peel it back, tip up the nostril till your fingers touch the outside of the nostril, and then give it a hard spray. While you're waiting for this medication to work, it didn't talk too much about it, but it's really important that the person we're trying to help gets oxygen. So we want to give rescue breathing. I guess I don't have a slide for this, but it's really easy to describe to you. The first thing I want to do is see if the person's breathing. We do that with look, listen, and feel, right? We put our face down near the person who's breathing, near their mouth. We can feel on our face if they're breathing. We can hear with our ear if there are any signs of respiration. And with our eyes, we can see if there's any movement in the chest. Look, listen, and feel is really easy way to see if somebody has any breathing. If they don't have any breathing, after you give them this dose, you need to give them some rescue breathing. 1 breath for every 5 seconds. 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000 breath. When you give a rescue breathing, you tilt the head back and lift the chin all the way back. You cover the nose, you put your mouth on their mouth, and you give a short breath. We don't blow people up like a balloon, right? Our lungs are only so big. When you give that breath, you want to notice where it goes. Is it moving the chest or is it moving the stomach? If the stomach is moving, they're going to probably throw up all over you once they wake up. So you want to just tilt the head back a little bit further for the next breath and make sure it's the chest that's rising and not the belly. 2 minutes of rescue breathing and another dose. 2 minutes of rescue breathing and another dose. 2 minutes of rescue breathing and another dose. If you're in Franklin and you called 911, you could be waiting 25 minutes for an ambulance. Depending on where you are in Macon County, you know, we don't have a billion ambulances like Buncombe does. And so it's really important for people who don't have immediate access to medical services like EMS, that they have extra doses of Narcan or naloxone available just in case. So what to expect after administration? You want to stay with the person. You know, once they wake up, you want to be kind and soft to them. You want to tell them what just happened. Hey man, I'm really sorry, but I came home and you were laying on the floor and you weren't breathing. I'm just going to stay right here with you and sit and make sure you're okay. You want me to call an ambulance? Typically they'll say, no, I don't want to go to the hospital. But at least stay with them and explain what happened and be gentle and really kind to them. They don't know what happened. They were just really high and then they almost died. So treat them really well. Treat them like humans, be kind to them, and don't push them to go to the hospital unless they want to. Stay with them. One of the side effects is the withdrawal symptoms. We talked about the precipitated withdrawal. You heard in the video about all the side effects that happen when you give somebody naloxone when they got opiates in their system. And so the withdrawal symptoms wear off in about 30 to 90 minutes. They can overdose again during that time. And they can also overdose later. And so we tell people who are using substances, do not use You're not going to be able to stop the withdrawal symptoms. Do not use anything. I don't care if you smoke a pound of heroin. You are not going to stop the precipitated withdrawal from the naloxone. Remember, we had that affinity. It's stuck on there like super glue. It can only come off when it's ready. So you want to de-escalate and support. And they do vomit sometimes. I guess I think the number I saw was about 35% of people that are administered naloxone for an overdose vomit. So that's why that rescue position is so important. Repeat doses are necessary. Sometimes 2, 4, 6. I've had several people tell me they've used 6 or 8 doses to reverse an overdose. As they awaken, they're not themselves, right? If they begin to vomit, get them on their side. And if the person has not used any opiates and that's not what the problem is, and you give them this medication, it's not going to do anything. It's going to hydrate them, right? I could drink a gallon of Narcan and naloxone. If I don't have any opiates on board, it isn't going to do anything to me except hydrate me. Discourage them from taking drugs. They could re-overdose, that 30 to 90 minute window. I can't reiterate that enough. You just got to wait it out. Storing naloxone can be problematic. The nasal spray, I just showed you how little this medication is. It's teeny tiny. Look, it's the size of a pill, right? It's so small. So if you keep this in your car tonight, it's going to freeze. It's going to be 19 degrees. If you need to use this in the morning, it's going to be frozen. Tomorrow afternoon, it'll defrost. But because it was frozen, because it was in that high temperature, the low temperature for so long, it may not be as effective as it once was. I wouldn't throw it out. Maybe it's 80% effective than 100. 80% is better than nothing, right? Until you can get some new Narcan kits. The other thing is heat. So I hear a lot of people say, oh, I keep my Narcan in the glove compartment of the car. That's great. But your car's 120 degrees when it's hot, right? The windows are closed. And so when you go to use that Narcan from the glove compartment this summer, it's probably evaporated. There's probably nothing in the Narcan dispenser. So it likes temperatures between 59 and 77. It can go up and go down more on short periods of time, but not for long periods of time. So, if you do an outreach and you've got a backpack full of Narcan and it's 40 outside or, 20 outside, whatever, it's okay for short periods, just not long term. Don't freeze it. It helps to reduce the efficacy. It doesn't like the light. When we have the intramuscular kits, we use an amber colored plastic bag, which is just like this. This is what we distribute Narcan in my agency with. And so the amber bag helps to keep the sun off of the Narcan, which will then protect it from losing its efficacy as well. We say replace the spray before the expiration date, but there's been studies that have shown that Narcan has been good to use even after 30 years of expiration. So there's a national movement to try and collect all those expired naloxone doses from the police departments, right? Let's get them and give them out to the people who use drugs because they're still good. Don't throw them out. If you've got Narcan at home and you need a new kit, you don't feel comfortable using an expired kit, just let me know and we'll get you one. So storage can be a pain in the butt. So is naloxone enabling? I hear this all the time. Oh, you're just enabling people to get as high as they want. And then you just give them Narcan and they're okay, right? They can get as high as they want to. Okay, if you say so. The big thing about Narcan is that it enables breathing. It's not a treatment. It's a medical intervention. The only thing it does is remove the opiate from the receptor and let the brain breathe again. So, dead people can't recover. If I can't help save people's life with the naloxone, what are we going to do? Think of 100,000 people that we've lost this year in the United States. We're over 1 million people that we've lost since the beginning of the epidemic. Without naloxone, those numbers would be even more catastrophic than they already are. And it really is about preventing death. How do we prevent death? We don't encourage people to use drugs. Naloxone doesn't encourage people to use more drugs. It just helps keep people who use substances alive and healthy. All right, so any questions about overdose with opiates before we move on to some harm reduction and then take questions? All right. So our syringe exchange program of Franklin opened in, well, it opened underground a long time ago, but legally, I think we opened in 2016. The reason that we opened a syringe exchange program is this photo. So on the left, this is a picture from diabetesdaily.com. On the left, you have a brand new sterile needle. That needle is pointy and sharp, but it's paper thin. They're so thin. They're made for one-time use, and then dispose. In the middle, you have a needle that has been used once. Can you see the barb on the end of this needle? This is one-time use. So this biomaterial, blood, skin, whatever, all of that, right? This is a needle that has been used 6 times. 6 times. Some people who use methamphetamine use 6, 10, 12, 15 times a day. So can you imagine what this needle would look like after being used 15 times in a day? Look at this. This is all being injected into the body, which then causes bacterial infections like endocarditis and sepsis, which, causes death. This is a really serious issue. It also damages the skin, causes abscesses and infections, bacterial infections, necrotizing fasciitis, all kinds of stuff. And so this slide is what motivated me to want to help people who inject drugs. This is the reason that we do it. And notice I didn't say a clean needle. This is a sterile needle, comes out of a package sterile. And when they're used, or we don't say dirty. I'm not saying any clean or a dirty needle. We're going to stay away from that language. According to North Carolina General Statute 90-11327, this interestingly is the police body cam law. The syringe exchange law was haphazardly attached to the back of this law, kind of in a backdoor deal, I guess. But here we are attached to a police body cam law. It makes sure that people who are operating an authorized syringe exchange program are providing safe disposal of used needles and hypodermic syringes. So anybody who's using a needle for any reason can come to us and we will dispose of them in a safe and healthy way. We have to provide new needles, hypodermic syringes, and other injection supplies free of charge, and also in sufficient quantities to ensure that they're not reused or shared. Some programs in the United States will give, if you bring me one used needle, we'll give you a sterile needle. So it's 1-for-1 exchange. Sometimes if you bring, whatever you bring, we'll give you 3 times that. So you bring 3 needles and we give you 10 needles. We are not a location that does that based on North Carolina law. We distribute in sufficient quantities. So for example, we have folks that are doing what's called secondary exchange, and that's when they come and share the supplies with their folks. Sometimes I give them 100 needles, and that's really not a lot. So people say, oh my God, you gave them a whole box of needles. Well, yeah, they don't have transportation to get here. Whatever the reasons are for them. We have reasonable and adequate security, right? We have a lock on the front and back door. We provide lots of educational materials on anything possible, you name it, and I can share some information about it, I'm sure. We have to provide access to naloxone kits. We actually provide the kits, but we have to at least provide a referral. And then if somebody's requesting a particular service, maybe they're looking for treatment services, we have to be able to provide a referral to them for them to get help with whatever they're asking for. So that's our syringe exchange program. I always end with my brother, Michael. We lost Michael. It'll be 10 years ago this April to an opioid overdose. I have to add my brother Jimmy. We lost Jimmy on Halloween weekend. So I've now lost two brothers to opioid overdoses, despite doing this work for more than 20 years. And so I still encourage people, let's continue to do this amazing work with each other and save lives. Carry naloxone, don't use alone. Use test shots, whatever we can do to reduce the harms relating to substance use in the people that we love. So that's it, folks. Any questions? What have we got in the chat? Did we miss anything good?
I think Pam
Absolutely, you
said
can have my
something.
email. I'll type it in.
Yeah, I was just going to say, since we're at the end of our time, if anybody has any additional questions, they're welcome to email those to myself or Stephanie, and we can make sure they get answered for you. It does look like Pam asked you something.
Yeah. Let's see, Pam, with need for Narcan based in Oregon nationwide. I was listening in my car. I heard something about being able to get Narcan, brand new not-for-profit 501c3, not yet granted. So you can definitely email me and I will help you get connected to naloxone for sure. Just email me at stephanie@radicalloveheals.org and we'll make sure we get you connected.
Yeah, thank you so much, Stephanie.
You're welcome.
This information is so important, and I hope that we can keep spreading it and reducing stigma on this stuff so that we can save some more lives. Thanks for doing the work that you do.
Thank you. We can't do it alone. The folks that help us, we call them muddy angels, right? We like to get dirty. And the fact of the matter is that we need 100 more people. So if you don't have naloxone, you can get on to Next Distro and they'll mail you naloxone, or you can message me and I'll make sure we get you connected. Got plenty.
Also, Suzanne asked if they're able to get the slides.
Sure, absolutely. I'll send you the presentation.
Suzanne, do you want to put your email in the chat so she has that?
How about if I send them to you, Bex, and you can send them out to everybody who registered?
That works great. And if any of you all need a certificate for CEU credit, also shoot me an email. I believe I emailed all of you, so you should have that from me. And thanks again, Stephanie. I hope that you have an incredible rest of your day, and I hope the rest of you all do as well. Stephanie, or Suzanne, I got your email, so I will make sure that you get that sent to you.
Thanks for caring, guys. You know, these are our folks, our kids, our partners, people we work with. Everybody uses something.
Yeah.
Whether it's coffee, whether it's vape, whether it's, you know, reading romance novels, we're all addicted to something. So don't judge somebody else. Let's just try and get people as healthy as we can. Everybody deserves a chance to be healthy.
Yeah. Oh, I agree completely. I hope you guys have a great night. Thank you, Stephanie. I'm sure I'll see you around the community. So we appreciate you. Bye, everybody. Have a good night.